What you're going to hear today are the results of this, the first case of a pilot study, this FDA-approved pilot study of deep brain stimulation specifically for treatment of TBI. So this is a collaborative project that involves Cornell and New York Presbyterian Hospital. Nicholas Schiff is the PI there, and he is credited with conceiving of this project. An animal lab and had been doing work with animals along these lines and got ready to make the move to humans, and we met somewhat coincidentally, and I was interested in similar things but coming at it from a completely different angle. We got together, and then also partnering is the Cleveland Clinic, which is the neurosurgical arm of this project. So we have the neurology arm here from Cornell, the neurorehab arm, and then the neurosurgical arm. And Ali Rezai is the surgeon who does the implants, and his team. Lots of supporters, both in funding and in other resources, but I will tell you, because partly for disclosure purposes, that this is an FDA trial that falls under an investigational device exemption application. So this is sort of an off-label, an off-label use of the stimulator. As you know, it's approved for Parkinson's disease. It's in fact the same stimulator that's used for Parkinson's disease. And then also, I want to acknowledge Intellect Medical that provides partial funding for this study. Generally speaking, the purpose of this project is to determine if deep brain stimulation, as applied to the thalamic intralaminar nuclei, ILN, of patients in the chronic form of the minimally conscious state can facilitate further functional improvement. Now, by chronic form, you'll see this later, but I'm talking about patients who are more than a year post-injury. So the lion's share of spontaneous recovery, if not all of it, has occurred by the time they're eligible. So where does this idea emanate from? Well, as you all know, certainly, there is no existing treatment that's been proven to alter the course of recovery from acquired brain injury. And some of you may know that about the minimally conscious state. And this is a condition of severely altered consciousness in which a patient shows minimal but definite evidence of self or environmental awareness based on behavioral assessment. So you can imagine that the permanent form of this condition, the minimally conscious state, is essentially a pretty devastating condition in terms of the functional, social, economic outcomes. Some people have suggested, some neuroethicists have suggested that this is a worse outcome than patients in vegetative state who have no conscious awareness. There's a lot of argument about that, but the point is few people would disagree that it's a pretty devastating outcome in its permanent form. We also know that recent fMRI findings, some from our other work, other lines of research that we're working on, but also from other labs, have indicated that patients in MCS have fairly, not all, but have widely preserved cortical networks subserving language and visual processing, despite their inability at the bedside to demonstrate consistent command following or reliable communication. So there's this disconnect between what the brains of these patients appear to be doing when you look at them with functional neuroimaging and what they do at the bedside. It raises all kinds of questions. We are certainly not the first to do DBS for TBI. Early studies were done in the US dating back to in the 1970s. Many of you may not know that Terry Schiavo had deep brain stimulation, and one of the reasons that there's a big argument about why she never got an MRI scan along the way. One of the reasons is that she still has the electrodes in her brain. But also, the second wave was in the 1990s, mid-1990s, out of Japan and France, where a couple of groups also got interested in whether DBS would help TBI patients. But they focused on vegetative patients. They were not looking at patients with any signs of consciousness. These were completely unconscious patients, at least by their characterization. And they were targeting different regions than we are now. So they were looking at the central median nucleus of the thalamus and the midbrain reticular formation. Interestingly, though, they did document increases in cerebral metabolism, in EEG desynchronization, which is a good thing, and physiologic and behavioral signs of arousal, And contrary to some claims made in these papers, most people do not believe that they demonstrated any clear evidence of improvements in awareness in these patients. But the point is, the neural substrate did appear to be changed by use of deep brain stimulation at a minimum. So what's so special about the intralaminar nuclei? Why is this the target now? Well, the ILN influenced corticostriatal palatal thalamocortical loop circuits of the anterior forebrain. So we're talking about a wide swath of brain that they have potential to modulate. Although they provide this sort of wide recruitment or can provide wide recruitment of activation, it's also selective in that the ILN have specific targets that they project to in downstream cortical fields. So if you get to the right spot in the intralaminar nuclei, you can influence activity in various regions of the frontal lobe, in the temporal lobe, and the parietal lobe. And they're comprised of neural populations that selectively activate and modulate, that's the key, modulate cortical signals that are related to critical cognitive functions like vigilance, sustained attention, motor intention, and working memory. So here's a graphic illustration of the projection. So here we are in the thalamus. This is the area that we're interested in. CL is the specific target, the centrolateral nucleus. I referred before to CM, the central median nucleus. So this is where we're putting the electrodes. And you can see that the CL projects to both mesial frontal, and for those of you interested in neuroanatomy, this is the cingulate, and we know the cingulate has a big role in things like vigilance and response preparedness, etc. But also dorsolateral frontal areas, and then parietal, and so on. CM, which is probably also being influenced when we stimulate, because we can't control the spread of the stimulation that well, projects primarily to the basal ganglia, so we may well be getting motor effects of DBS as well as cognitive effects. And in the first case, we think we saw that. So I don't have time, I don't think, to have you try this, but this is a binocular fusion slide. So you can try it while I'm talking. So what you want to do is make the image on the top a 3D image. So the way to do this, if you can, is to pick a point here, cross your eyes a bit until you get 3 images. So if you cross your eyes enough, you should be able to pop up 3 images. And then you want to just focus on the center image, and then relax your eyes. And what you'll get, if you can do it, is a very clear 3D image that shows, why am I making a big deal of this? So right here in black, so you really can't see this at all on this slide, but the lines are drawn in different colors. So the point is that these are the centrolateral.
Got it.
You got it?
I practiced this morning.
He did. It helps to practice. It's very neat once you get it because it's a pop out and it just turns into a 3D image, and you can see that. You can see the unique features of the ILN, which are that they are centrally located in the thalamus, as opposed to the other thalamic nuclei that have predilections to certain regions. And then the other thing is that if you can follow these lines in the 3D image, they go to all of the other thalamic nuclei, and they're the only ones that really do that. So that's important because insofar as the other thalamic nuclei have specific targets to frontal regions, parietal, occipital, and temporal regions, color-coded, CL has the capacity to influence all of them by virtue of these connections to the other thalamic nuclei. So, and this is the cat brain, by the way, in case you were wondering. Anybody else able to fuse the images? Ah, we got one person. Okay. All right. So, okay, with that, with a little bit of background. So what would be an appropriate therapeutic aim then for DBS for cognitive facilitation after TBI? So you can think about this, and we did when we planned out this project, along a continuum with a longitudinal plan. At the moment, we're here. So the idea is we're going to start with patients with the most severe disability after TBI. and specifically patients who meet the diagnostic criteria for MCS. And one of the hallmark features are these are patients who show signs of consciousness because they can follow some commands. What they cannot do is communicate in a functional manner. So they may have a yes or a no response, verbal, gestural, or otherwise, but they can't execute that response either consistently enough or reliably enough that you can depend on it. So the hope is that with DBS in this population, we can take patients in MCS and bring them to the point where this rudimentary communication system becomes functional, and they are now functional communicators, and that's a game changer. Down the line, and there are already beginnings of the work being done, is to move into patients with moderate disability. So these are people who might have had a severe brain injury, but now are left with moderate disability, which has, interfered with their independence to some extent. So the question is, and they're probably independent in ADLs or partially, can DBS get people who have partial independence in things like self-care and ADLs to the point where they're now independent? And you can even take the argument further downstream to patients with mild disability and ask whether DBS has a role in patients who maybe even had a mild TBI which has left the person with cognitive slowing that is completely disabling, because they can't perform the job, the career that they did before, because it depended on normal to higher than normal processing speed. So can DBS speed up the delays in processing speed? So this is the kind of the longitudinal plan. A little bit about how it works. I'm not going to go into detail here, but I think you probably want to know a little bit about this. So this is an actual scan showing, I think actually, I'm almost certain this is patient 1. This is patient 1. So the way this works is the surgeon begins by drilling a burr hole in the skull and then advances through stereotactic guidance a catheter down into the thalamus. So here's the thalami on either side of the third ventricle. Advances the catheter down into the thalamus. And then using neurophysiologic monitoring, which records the activity in specific cells, determines when you're in the centrolateral nuclei or a different nucleus. And it's done, I can't go into detail now, but by doing functional mapping. So by rubbing the patient's arm, if you're in the right place, if the electrode's in the right place, it will pick up firing cells that fire to tactile stimulation, cells that fire to kinesthetic stimulation. So using this combination of stereotactical imaging guidance and neurophysiologic monitoring, you can find the target. So the other thing I want you to just be mindful of here is that this electrode, and then once the catheter is in, I got out of order here. So the catheter goes in through the stereotactic guidance, then the electrode is inserted, and the neurophysiologic monitoring is started until we find the target. The electrode has 4 contacts in this particular configuration of electrode, each of which can be activated individually. At the top of the electrode are the wires that are snaked under the scalp to the back of the head, down the neck, sort of behind the shoulder, then into the chest wall, and the internal pulse generator, a little box about this big, is implanted in the chest wall. And the wires are hooked up to the internal pulse generator. This is, you can actually see that this has been doctored, this slide, to some extent. There's another track here because this patient got bilateral DBS, and that's how this project is working. We're doing essentially only bilateral DBS. So once the DBS system is implanted, the next step is to titrate the stimulation parameters, figuring out a couple different things. So first of all, what's the intensity of stimulation? And these parameters are titrated to optimize behavioral performance. So you're modulating these parameters to see what seems to promote the best performance in terms of either cognitive or behavioral function or motor function. So one of these parameters is amplitude, or the intensity of the stimulation, in voltage. The pulse width, how far will the spread of electricity, if you will, go in the brain. and then the rate, the rate of the pulse rate or the frequency. So we take now 2 weeks to figure this out, and in the first case, and we're 3 cases in the first case it was 3 months to figure it out, but we got a lot of leads on the first case that help us do this faster now. You can do DBS as in a monopolar configuration where one electrode is active one contact point is active on the electrode, and then it's essentially hooked up to the IPG in the chest wall, and that controls the direction of the spread of the stimulation. You would use a monopolar configuration if you want a larger field of brain being stimulated. On the downside is that you can't titrate it in the brain that well, and you may be getting other regions, you may stimulate other regions that you don't want to stimulate. A bipolar configuration uses a cathode and anode configuration on the electrode. So what this does is it draws the direction of the stimulation within the specific contacts. So what it does is you can see it narrows the field and the spread. It also gives you a more intense field and would presumably limit unwanted side effects because you're stimulating nuclei that you don't want to stimulate. This is a 3D reproduction of what the spread of stimulation would look like. So here's the electrode in the centrolateral nuclei, and this is showing, so the electrode is active at contact 0 on the bottom, and this would be sort of the ball of stimulation that arises from turning that electrode on. If you then turn on contact 2, the ball of stimulation would cover the CL in a different configuration. Okay, so these are the kinds of things that have to be figured out in advance to some extent, but then during the process of implanting and titration. All right, so moving into this particular study and the results. So the aims of the study were to determine whether DBS can promote behavioral responsiveness as well and improve functional outcome in patients with chronic MCS. Second, to determine whether the treatment effects result in sustained cognitive improvement. So do patients continue to hold on to these improvements after the fact? And then lastly, to look at the frequency and severity of adverse events, which is obviously critically important. So real quickly, who's eligible? Has to be traumatic brain injury. We don't have the authorization at this point to see patients with non-traumatic brain injury. They have to be medically stable. They have to meet the diagnostic criteria for MCS, which essentially mean that they're following commands inconsistent. They show either inconsistent command following or intelligible verbalization or communication that's unreliable. Have to be 12 months or more post-injury. Recovery has to be plateaued. More about that in a minute. And the age range is between 18 and 55. And they have to, of course, have a legal surrogate available to consent, since clearly these patients cannot consent for themselves. Exclusion criteria: they cannot have a large volumetric infarct involving either Broca's or Wernicke's area, because those are the areas we're most interested in, because we want to promote recovery of speech and language functions, and obviously much is built on a functional language system. Cannot have a paramedian mesodiencephalic infarct, which would kind of disrupt that circuit. So even if we stimulate the CL, there's going to be disruption further downstream, or in both directions, actually. Can't have a comorbid medical condition that reduces life expectancy to less than 5 years. No contraindications for general anesthesia, et cetera, et cetera. It can't be quadriparetic because we want to look at the motor effects. So we may get somebody who is responsive in terms of the motor system, but they're quadriparetic and can't show us that responsivity. This is patient 1. We've redesigned the study since, but I'm going to just tell you about this. So designed in 4 phases. First, a pre-surgical baseline during which traditional rehab interventions are reinstituted. So these are patients who are getting rehab like most rehab centers would provide it at the same time as they're going to get DBS. In the first case, the pre-surg baseline lasted 109 days. And the purpose of this is to establish their modal neurobehavioral profile. So where do they kind of live on the average day? What's their typical presentation over time? And we need to be sure the recovery trajectory is flat. Following that, the patient goes to surgery, which is performed at the Cleveland Clinic, and they go into a post-op. Case 1 went into about a month-long post-op eval period, during which we are confirming that the electrodes are correctly placed and titrating the stimulator so that we can establish safety. Then the formal titration phase, where we're trying to figure out the optimal parameters based on the patient's behavioral response when we change amplitude, pulse width, pulse frequency. And then lastly, once all that is done and we decide which is the best titration, which is the best DBS profile, it's locked, and we then go into the actual treatment phase, which is a 6-month alternating crossover trial. 30 days of blinded, so we don't know on or off, but 30 days on, 30 days off, 30 days on, 30 days off for 6 months. So you get 3 months of on and 3 months of off. Primary outcome measure, John alluded to this before, is the JFK Coma Recovery Scale Revised, which is designed for patients with disorders of consciousness. What we elected to do with patient 1 and have continued to do with the other patients is to look at as the primary index the frequency of the best score, because some of these patients come in and they get the top score sometimes on the subscales, which look at auditory functions, visual functions, motor, verbal, communication ability, and arousal. They may get the top score, so we're not going to really be able to see a step up or stepwise change. But what we can see is it may be that the patient is getting the highest score 20% of the times they're examined. What we want to do is make that 100% of the time, which is closer to what normal should be. And we also built secondary outcome measures. You can just go right through these. That gave us, or designed to give us more information about the impact of DBS on arousal. The first case, if you can just stop for a second, despite the fact that he was awake, his default state was eyes closed. So he would sit all day long with his eyes closed, awake, because he would be responsive to commands, but he didn't open his eyes. And I'll jump the gun by telling you, when we turned the stimulator on, one of the first things he did was open his eyes and visually fixate, and was much more vigilant to the environment after that. Expressive speech, we're looking at naming. Purposeful limb movements, we built scales to rate these things. Could the person demonstrate functional use of common objects, and could they make communicative gestures like waving, return a handshake, etc. And then we also fell into looking at dysphagia because we had no a priori intent to look at swallowing. But during the period of titration for patient 1, the speech pathologist started to tell us that swallowing was improving. Again, we're not looking at that specifically. And then decided, well, let's see what happens over the course of the trial, and built a dysphagia rating scale to look at how much assistance was needed for oral intake. He was NPO completely at the start of the trial. So how about the first patient? Who was he? So a 33-year-old right-handed male who had a blunt head injury as a result of an assault. He was from Trenton, actually, and was assaulted. I don't know where he was returning from. Had bilateral subdural hematomas, worse on the right side. Initial GCS score was a 3. He progressed from the vegetative state to the minimally conscious state after about 2 to 3 months post-injury, which is not uncommon. But then after he got to to MCS level, so to speak, his recovery essentially arrested. And he spent the next 2 years in an inpatient rehab setting, didn't change much at all, and then was sent to a nursing home for the next 4 years. We were able to maintain contact because he would come back every once in a while to our facility to see the physiatrist who had initially treated him. So this period was spent at our place. During this entire 6.5-year period, he was completely dependent for care. He had no ability to communicate at all with anyone. We bring him back in, again at 6.5 years, specifically now for this study. At the time of admission, he's showing inconsistent command following, just like he did when he left. He was nonverbal, although there were a couple really rare single word verbalizations that tended to be hypophonic. They were intelligible either because you could make out the word mouthing, or some of them there was enough, they were audible enough to be able to hear what he was saying, but usually would be a single word and that was it, and hardly ever did that occur. He showed occasional head nods for yes and no, but was not close to having a reliable communication system and had no capacity to use objects. So he was still in the minimally conscious state at the start of the study. So his MRI on readmission, you'll see a quick picture, showed pretty dramatic right frontal encephalomalacia, so a loss of tissue as a result of the blunt head trauma. He also had a small right paramedian thalamic infarct, which is important for us because we're stimulating the thalamus, believed to be secondary to herniation during the acute phase. So this is basically MRI with fMRI data co-registered onto it. So the point here is, here's the lesion at 6.5 years post. So he had very little of his right frontal lobe left. And you can see obviously atrophic changes on the left side as well. But the important thing is when we took him for our fMRI paradigm to look at language and visual processing in MCS patients, he showed robust activation of the language system, despite the fact that he didn't speak. He inconsistently followed commands and was not and barely ever showed any yes/no responses. But you really could not tell, except for the fact that the right hemisphere had no substrate to activate. This is really very normal looking. So a normal control would look very much like he did. And I don't have time to go into it, but he showed robust activation across the conditions that we use in this trial. So the bottom line is, looked like he had viable substrate. This is a somewhat manufactured rendition of what his stimulators look like, or his electrodes look like. So he had one on the left, one on the right, and you can see there's a different configuration for each. So this was, I think, monopolar on the right and bipolar on the left. One of the reasons that monopolar would be conducted on the left is because he had the lesion on that side, so he was missing thalamus. So you want to capture more structure, to get stimulation to a bigger area. All right, so how about the findings? I gave you the reference if you're interested in looking. They were published last year in Nature. All right, so let me walk you through the results. So because we were concurrently doing traditional rehabilitation and DBS, so we were getting both of them at the same time, it was obviously necessary for us to parse the effects of rehab from the effects of DBS. So the way we have shown these data is this graph shows the cumulative hours of either rehab, which is this black line here, or DBS exposure over the course of the study. Now, this begins at 300 days before the crossover phase, before we actually went into the on-off period. So what you see, and this is not surprising, he started, this is rehab, which began well before the DBS trials began. And he accumulated rehab hours in a linear manner because he was getting the same number of therapy hours, the same number of days a week. So that remained constant across time. But the DBS exposure occurred in a very different manner. So we had a period of nothing for a long time, and then a rapid ramp up in the number of hours that DBS was on. So it ramped up at a faster rate than he was accumulating therapy hours. And it was irregular. It wasn't constant because we would turn it on for a while and turn it off for a while. So you can see the trajectories of hours of exposure of DBS and hours of exposure to rehab are very different. So rehab goes on board here. Surgery occurs right around day 200 before crossover. DBS gets turned on for the first time around day 150. This is for titration to begin to figure out what the best parameters are. So what you're going to see here now are the plot of the scores that he got on the coma recovery scale on 3 subscales. We chose 3 subscales because they were the best ones for this particular case. I'll skip the rationale for that. So carrying this line forward or upward, everything to the left of that dotted line are scores on the coma recovery scale before DBS was on, and everything to the right are scores when it was turned on. So first of all, let's look at what happened with the oromotor verbal subscale, which looks at a score of 3 is assigned if you can demonstrate on examination that the patient has intelligible words on that examination. You need to show at least 2 verbalizations that are fully intelligible to get a score of 3. A 2 is assigned if the patient can vocalize, but there are no intelligible words. So you can see that the patient never had a 3 during the time we were monitoring up to the point of DBS, and then right in sync with when DBS goes on for titration. We did not anticipate this. We did not expect to see immediate effects during the titration period. But in fact, there's this stepwise change, and now he gets exclusively scores of 3 during the titration period. We're not even at the crossover yet. On the arousal subscale, a score of 3 is given when the person is able to respond to verbal prompts pretty consistently in a 30-minute session. So the operational definition is if there are fewer than 3 times that the person fails to make a response to the verbal prompts that fit into our standardized exam, they get a 3. A 2 means that there are lots of times they're not responding, but they maintain wakefulness. Their eyes stay open throughout that time period. And then a 1 is given if if you have to do some type of sensory stimulation to keep the person awake. So up to during the point that DBS was off, you can see there were a couple scores of 3, but primarily scores of 2. And then when it gets turned on, there's a flip-flopping of the frequency. So now he's primarily getting scores of 3, which means that his responses are much more consistent than they were before. And lastly, on the motor subscale, a score of 6 is given when the person's able to discriminate 2 objects and can demonstrate how they're used. Gets no scores of 6 during the period of DBS off. 5s are for automatic movement. So a return of a handshake gesture gets a score of 5 on the coma recovery scale. So he was getting scores of 5. Turn the DBS on, and he gets his first score of 6 shortly after it goes on. And now he's going back and forth between 5s and 6s, but you can see he's getting 6s now at a pretty good clip. So what we're looking at here is the comparison of performance along the primary outcome measures. These are the 3 from the CRS, arousal, communication, and motor subscales, and then 3 particular secondary measures, which I talked about before. We're looking at the comparison is what was his performance on the measure before surgery, that's pre, during the on period, so the 3 months on collapsed, and then during the off periods, 3 months off collapsed. So what are we looking at? The frequency of the highest score on each of these measures. So you can see that for the arousal subscale on the CRS, prior to surgery, he never got the top score. We look at the DBS on period, and he's now, by the end of the trial, this is all the 3 months on collapsed, he's getting the top score almost 90% of the time. Shut the stimulator off, and what's very interesting is you get a significant drop in the off period, but doesn't fall back down to baseline. So there's a carryover effect, it appears, even though the stimulator has been turned off. Similarly, for the, let's skip over to the limb control secondary measure. Prior to surgery, never got the top score. These are error bars, by the way. And then when it's on, about half the time he's getting the top score. Turn it off, significant drop, but again, well above baseline, maintains at a little bit less than 40% relative to the 0% at baseline. And then lastly, on the dysphagia scale for oral feeding, he has, there's a green arrow because we didn't monitor it pre-surgically. We had no reason to believe it was going to change. So, but if you look at the on and off, about 75% of the time he's getting the top score on the dysphagia rating scale, drops significantly, but again, he stays at about 40% of the time getting the top score. So we can take from this that just a marked change from his baseline pre-surgical state with DBS on, shut it off. There's a significant drop as we would anticipate, but it remains well above baseline, so there seems to be a carryover effect. The DBS effects don't just stop when you shut the stimulator off, which is often the case with DBS for Parkinson's disease. And any of you who've seen this know that. Just concluding now. So in our view, these results support DBS as a treatment that may be able to modulate specific cognitive and behavioral functions, specifically arousal, limb movements, swallowing. And we see this because our target behaviors occurred more frequently with DBS on relative to off. We saw some evidence, as I just pointed out, of carryover effects, particularly for speech. The example here is that intelligible verbalizations were noted on 60% of the trials that were administered with DBS off. But remember, the DBS off followed the titration period where we initially saw intelligible verbalizations, and he had never had them at the pre-surgical baseline period. Why does it work? We know that the centrolateral nuclei co-activate with the anterior cingulate and the supplementary motor area. Remember those arrows, those colored arrows I showed you in that illustration? Well, that mesial frontal circuit is critical for mediating things like response preparedness, motor intention, drive functions. And so, he had the substrate, but he could not push these functions and these pathways well enough on his own in our estimation. So what are the implications going forward? Well, one possibility is that DBS may be able to be linked to treatments like cognitive rehabilitation or other drug interventions to boost effects even further because of the fact that we're directly impinging on neural systems, not using, accommodative strategies like cog rehab typically depends on. So these combination therapies might be able to then improve all of the things that we work every day on: sustained attention, intention, executive functions, awareness even, working memory. And then ultimately, if we can impact these functions, we are moving forward toward restoring functional capacity and ultimately independence. Okay.
When the stimulation is on, like, how long is it on?
Okay, so the question is how long, when the stimulator is on, how long is it on? So we use a 12-hour duty cycle. That's actually the fourth parameter, is the duty cycle. So it's 12 hours on, 12 hours off. In the current patients who are in the trial, it goes on at 8 a.m., goes off at 8 p.m. We don't want it to interfere with sleep, obviously. And patient 1 is well into the open label phase, and he's on that same schedule that he was when he was in the trial. Marna?
How many on-off cycles are there over the entire experiment?
So, if I'm how many on-off cycles are there over the whole?
Yeah.
So
you said on-off, on-off.
You don't mean daily. You don't mean counting daily. No. Yeah. So there's 3 months on, 3 months off, but it's alternating. So first month is either on and off, depending on how the patient was randomized. Next month, so if they were on month 1, they're off month 2. On month 3, off month.
So is it possible to look at whether there are cumulative effects over the 3?
Yeah, I have actually other slides where we did plots of every point, and it turns out that it's very difficult to analyze the data for a lot of reasons, but there are you do get some better appreciation of what's happening, so you can see this kind of spillover effect with, when you look at the end of an epic and the beginning of the next one. So, I don't know that we elected not to submit it with the rest of the data because it was somewhat dirty, but we were in the same thinking plane about that. John.
So I don't remember whether you reported data in the interval between electroimplantation but before stimulation began. Do you do behavioral assessment during that interval? And the reason I ask is just hypothetically one could say, could any of this effect be a lesion effect as opposed to a stimulation?
Right, exactly. And that is a very legitimate question. The answer,
since there was carryover, that might mean it's not the standard.
Right. So the answer is we did, and I in fact forgot we did until just last week when I had to go back and look at the data. So there is data there. We didn't analyze it, but we were still collecting data. Now, because the reviewers, as you may remember, took up this issue and said, you know, maybe the surgery did this. I should also tell you that I didn't show the additional analyses that were done that pretty much put that issue to bed. The bootstrapping analyses that were run at Cornell. I'm not going to talk about it now, but they looked at very complicated mathematical analysis that's way over my head that looked at the relationship between the timing of the stimulation, the scores, and I think the number of hours again of exposure, and does something with those data and is able to separate out the behavioral performance when you get the package from DBS of those three variables against the package of those three variables for rehab. It's easier to talk about this with the slides up. So the point is, we were able to address those concerns statistically. What we've done in the long run is change the design. So we now have pre-surge, 30-day pre-surge period to determine pre-surgical baseline, a 30-day post-op baseline that we need to do statistics on, do stats to determine that there's no significant difference when you compare pre and post. People thought there might be gene expression effects from the surgery that could have, caused this. So we decided to preempt future reviewers and added. It's turned out to lengthen the trial, obviously. So now it goes 30-day pre-op, surgery, 30-day post-op. It's actually 10 days of EMU monitoring, epilepsy monitoring unit to look for, we do evoke potential studies and a bunch of other stuff. Then 30 days post-op, then 30 days titration, and then 6 months crossover. And you can only do this if you have a subacute facility where, you can keep these patients. Tessa.
The communication results are really remarkable. I have just have a question. I'm not familiar with the CRS. I know, I'm sorry, everything. What kind of response are you?
Yeah. So the communication subscale is a 0 if there's no discernible evidence of even an attempt to communicate. So nothing happens. The prompts are all yes/no questions for what we call situational orientation questions. They don't require, any memory. It's, am I touching my ear? Am I touching my ear? So there are 6 of those. We have a visually based set and an auditory based set because sometimes we run into patients who are cortically blind. We don't know that. So it's, am I clapping my hands right now? Am I clapping my hands right now? 6 of those questions are administered, and we just score how many out of 6 they get right. So if there are 2 or more out of 6, they get a score of 1, which means there's discernible communication responses, but they're not reliable. Reliable in our definition means 6 out of 6 responses, all correct. Suja? Sorry.
Any concurrent use of a psychoactive?
Not planned. In this case, the patient was on a low dose. It turned out to be accidental. We didn't really know it initially. Was on a low dose of bromocriptine, but the bromocriptine never changed throughout the whole thing. We decided, we had a lot of discussion about whether we should wean patients off their meds, but you can't really do that because you may change their pre-surge baseline. So the last 2 patients, whatever they came in with, they stayed with, but wasn't changed. So,
Side effect profile?
Yeah. Don't have the full answer yet, but I can tell you just anecdotally because, I can tell you anecdotally. We see significant frequency of dystonic posturing, which has been reported with Parkinson's disease. Part of the problem is that in the cases we've had, they've all come in with episodes of dystonic posturing. What happens is they tend to occur in clusters. So there is some reason to believe that we may get increases in dystonic posturing as a result of DBS. So clearly dystonic posturing is something I'd be on the lookout for. Seizure frequency, there's no clear pattern that's emerged yet. So again, I think So this case I just presented had a premorbid, or actually post-injury history of seizure. He also tends to have no seizures, and then he gets a cluster of seizures, and then they stop again. Doesn't seem to be directly related, but we don't know the answer to it yet. So, and then what else? So seizure, dystonic posturing. One of the things that is interesting is the autonomic changes that you see. So everything from pulse ox to respiratory rate. These things we have not monitored. They go up. They're often suppressed. The patient that's in now, patient number 3, had pathologically low ABGs or abnormal ABGs. So he's going to be very interesting because he was the most compromised in terms of these autonomic functions. We saw from patients 1, and particularly patient 1, that his autonomic system normalized to some extent, but he wasn't as bad off as patient 3. So patient 3 is still getting supplemental O2. We had to trach him to do the surgery because of concerns about, a 10-hour surgical procedure with compromised ABGs. So, that there may be benefit in that regard. You see changes in heart rate immediately, blood pressure, and not surprising because this is all the arousal circuit. But, so we don't have the fully fleshed out AE profile yet.